behind if anybody wants to talk one-on-one. All right. So, going through this review, you guys know your anatomy, upper, lower airway. Remember that distinction is the vocal cords. Right main stem, right? That's going to be your most common place that they aspirate some stuff or some object. So, right main stem. Why is it? Why the right main stem? Remember the innervations. So, sympathetic. Think exercise. What happens when I exercise in my airway? Bronchodilation, cilia starts kicking up more mucus and clears it quicker versus parasympathetic at rest. So we're thinking bronchoconstriction, increased mucus production. Now understand how those medications are going to work on those receptors too, right? So beta agonist is going to bronchodilate, muscle relaxation, and then muscarinic agent is going to drive those secretions. You get any question or scenario, right? What is this telling you right here? These things right here in the watch out for. Respiratory distress, right? If you don't intervene sooner than later, patient's going to go into respiratory failure. So those are red flags, those ones specifically. If they're sitting in that tripod position, posturing, extending neck, in that stiffing position. And then your rate rhythms right here. Tachypnea, greater than 20 for a test unless otherwise noted to be 26. Now understand the difference between those breathings. So if I, like in the lecture one, it had the breathing patterns, right? If I show you one of those, Q small, it's going to be rhythmic, but it's going to be those large, deep breaths versus chain stoats, which is going to have that waxing and waning, and then apneic, right? So that's kind of all over the place. Agonal means they're dying, right? That's going to be not following any pattern or any rhythm. It's just, and then maybe 5 seconds later is another breath, and then there's no breath for a minute, then 30 seconds, so it's all over the place. Breath sounds are really going to come important if we're talking about airway disorders, right? So what do we hear with croup? Barking, okay? And what is that indicating? The upper airway, right? So what about epiglottitis? Stridor, right? Think bronchi, if they cough and it clears, so what kind of disorder would that be with? COPD, what else? Bronchitis, right? Bronchitis, COPD. Are you going to have much cough in an emphysema patient? No. So chronic bronchitis, you're going to have frequent coughs, a lot of sputum, but with emphysema, you're not going to really hear much. And then what is clubbing indicating? Those extrapulmonary signs. COPD, right? Cyanosis, they're becoming hypoxic. Edema with COPD as well. So what do we think? What's that? Okay, why wouldn't it be A?
Air trapping.
Do we usually hear wheezing for asthma, especially initially on? Is it inspiration or expiration?
Expiration.
If you hear it on inspiration, what are we thinking? Yeah, it's starting to get worse, right? We're kind of a long out past that. Lecture 2, so chest x-ray, PA lateral, that's going to be your mainstay. That'll be for pneumonias. Majority of these patients, it's clinically indicated you're going to order one, necessary for the diagnosis, but to rule it out, right? CT, we're thinking further evaluation of some type of nodule mass found on the chest x-ray. That's going to be our study of choice. What is the study of choice for bronchiectasis? CT, right? That's how you're going to make the diagnosis for bronchiectasis and CT. VQ scan, what can we use that for? What's that? PE, right? And specifically, if I tell you you have a pregnant female, pregnant patient, suspected PE, are we going to order a CT?
No.
Or if they have a contrast allergy? No? So think about that, right? Now your chest x-ray patterns, lucency versus opacity, right? So I remember this is translucent, I can see through, right? So lucency, it's going to be less dense, I can see through it on the chest x-ray. opacity, right? That means I can't see through it, so that's going to be wider. So if I have lobar pneumonia, right, one lobe, is it going to be lucent or opaque? Opaque, right? Remember that. And then those patterns right there. So diffuse, if they get viral, it's going to be all over the lungs. It's not isolated to one lobe. It's going to be scattered. That lobar, think bacterial every time, right? Perihilar, what's that telling you? It's like the midline, right? Along the hilar. Multifocal seeding, what would that be? Cancer. What do we think? What? Cancer. Metastatic cancer, right? Could also be pulmonary too. We'll talk about it more, but there's other disorders that can do that. But for our purposes, let's say you get metastatic cancer. And then these are your advantages of bronchoscopy, right? So if you have a COPD patient, you need a sputum sample and they can't cough, how would you get it? Bronchoscopy, right? Also great for foreign bodies, right there. So we look at this and we just go through these test answers. So multi-lobar, right? Is it in multiple lobes? Yep. Okay. Is it just isolates to one lobe? Right? Because we have this mass right here. This. Is this perihilar? Right? So this one and this one, you could maybe make that claim if they were isolated. But this and these ones on the lateral aspects are definitely not, right? So E's off, B and C are off. Now we're just between A and D. Can you see them or are they dented? So what do we think? All right, that oxygen dissociation curve, or not oxygen, the carboxy or the oxyhemoglobin curve, you need to understand that principle, right? So if I have a left shift, what am I doing to that oxygen on the hemoglobin? I'm holding on to it, right? Because I don't need to give it up. If I have a right shift, I have lower affinities, I'm giving it away because the tissues need it. So if I say, which one of these findings would indicate a left shift, you would understand that, right? So compensation for the ABG, right? The lungs is going to be quick or slow? Quick, right? So if CO2 increases, what happens to my pH? It drops, right? So Rome. Think about that when you're breathing patterns. If you have that clinical case where a patient is tachypnic, what is going to happen to their CO2? It's going to blow off, which is going to do what to their pH? Increase it, right? So that is applicable to your asthma patient COPD. It's just a snapshot in time, right? So as they start progressing, they may not be able to blow it off. pH rise, what happens? Or CO2 rises, what happens to pH? Yep. Okay. And as far as the kidneys, they're either going to retain or eliminate bicarb. So if it retains bicarb, increases it, what happens to our pH? It goes up, right? So Rome, metabolic is equal. I'll have a bunch of practice ABGs too in the next lecture, or not lecture, but the PowerPoint I'm going to give you after this, so we'll get to practice it more. But start with that pH. Is it acidic or is it alkalytic? If it's normal, does that mean we stop? No, keep going because it may be compensated. And then we can go down to see if it's respiratory or metabolic related, and then you can see if it's compensated, uncompensated, or partially compensated. Does everybody understand when I say compensated, partially compensated, uncompensated? If you don't, raise your hand. This is the time to kind of discuss it. All right, we're all good on that? We look at this patient. On your test, there will be a bigger description. It's not going to be this short. If you have a question like this. The first thing we're going to do is look at that pH. Is that within normal range? Okay. We're going to keep going. Now, what about our PCO2? High. So if it's high, what would that usually do to our pH? It would drop it, right? So are we thinking initially, what is this? Respiratory acidosis. Now metabolic. Metabolic within normal range? Yeah, it's on the high end of normal range too, right? So would this be compensated, uncompensated? So this would be compensated respiratory acidosis, right? So this is pretty straightforward, but I'll have a few more test questions I'll show you to kind of understand a little bit better with the compensation. Hypoxia, if you ever have a question about that, you're looking at that O2 saturation. So if it's below 95 or whatever your normal range is, are they hypoxic? Yes. Yes, right? And then some kind of like this is past this test, but in real life, if you go to ICUs, they may say mildly hypoxic, moderately hypoxic, or severely hypoxic. We don't really know for this test, but in real life, if you go in your round 2 or your phase 2, you may hear that discussed in ICU on rounds. So lecture 4 is our pulmonary function testing. It's a tidal volume, that's just our normal breathing, right? So average is 500, and that middle number, or that middle part right there. Residual volume, can I do that with a regular barometry? No. So we're going to use sonography right here. What else? So what kind of patients would this be indicated for versus a regular? That? So restrictive or mixed, really, right? You could use it with emphysema because we're trying to see if that residual volume is going up because now they're air trapping and they're getting that hyperinflation. So can I get my total lung capacity with regular spirometry? No, right? So if I ask you how to calculate this and I don't give you residual volume, can you determine it? No. So vital capacity, this is the actual functional or working volume or capacity. So that's our inspiratory reserve volume plus our tidal volume plus our expiratory reserve volume. So it's normal breathing plus the deepest breath we can take in and the deepest breath we can blow out. So that would be right here, this portion, understanding that. Okay. If I say inspiratory capacity, what are we calculating? It's going to be the tidal volume plus the inspiratory reserve volume. If I say functional residual or capacity, right, it's going to be our expiratory reserve volume plus our residual volume. Standard PFTs, we already talked about that, indications, contraindications. What would be contraindications to a PFT? So if they are actively ill, right, they could have underlying disorder. Actively ill doesn't mean they have COPD, but if they had COPD with exacerbation, would you order it? If they're having an active asthma attack or suspected pneumothorax, yeah. And that's going to measure all those things. So pretty much everything that the other one's going to do except that residual volume. And then for our purposes, what we care about is that FVC, which is indicating what type of disorder. Restrictive. FEV1, FEV1 ratio. Which one of these is going to be for the diagnosis? The ratio, right? The FEV1 is going to be used for severity and reversibility test. It goes up flow volume loop. So this is inspiration right here. It's negative. We're taking a deep breath in, and then we blow out. So normal should be triangular shaped. Restrictive is going to be decreased volume. And then typically it's going to have a peak on it, right? And then obstructive, how do we know obstructive? Scoop. That scoop out, right? Remember that reversibility that differentiates between asthma and COPD? If it's greater than 12% and 0.2 liters, it is asthma. The methacholine challenge right here rules out asthma but doesn't rule in. So if you have a positive result, it doesn't necessarily mean it's asthma, but if they don't respond to it, then you can rule out asthma. Peak flow meters, not diagnostic, they're just more so to help our asthma action plans and determine if the patient's actually doing it. Remember, it's that red, yellow, green. Red meaning bad, green meaning good. And then pulse ox in comparison to our ABGs, you're going to have plus or minus 4%. And then what are things that can impact our pulse ox? Nail polish, what else? Cyanosis, right? Oh, yeah. They have no radial pulse and my pulse ox isn't working. So you'll have this chart on here. Don't know why on this it fell off, but you're going to have that too, which is, we'll talk more about that. That's going to be your severity for asthma. What is the answer? What is it?
54.
TLC, right? Anybody disagree that it's not E? Does anybody understand how it's not E? Right? Without that residual volume, you cannot determine total lung capacity. So these numbers right here would give you what? Yeah, functional vital capacity, FVC or VC, but it will not give you the total lung capacity because you're missing the residual volume. Common pulmonary conditions. Right, so you differentiate between acute, subacute, and chronic. Acute being that less than 3 weeks, subacute 3 day, and chronic greater than 8 weeks. So that if they have a cough for less than 3 weeks, and antibiotics are not indicated unless there's clinical signs or evidence of a bacterial infection. Right, so if somebody comes in with a cough and you get a chest x-ray and they have consolidation in one lobe, are we still thinking viral, or are we thinking what? Bacterial pneumonia, most likely, right? And then that post-viral tussive syndrome. So if it's before that 8 weeks, I just want you to think this is a post-infectious cough or tussive syndrome. And chronic, there's a number of reasons that can cause greater than 8 weeks, but these are going to be our most common. So remember, trial treat or trial hold. Trial treat for GERD and post-nasal drip. If it just says P&D, to talk about post-nasal drip. If it is a medication, ACE being your most common, we are going to think trial hold, real life. If they are uncontrolled hypertensive, anytime you hear uncontrolled hypertensive, what else do I want you to think? Sleep apnea, right? So obstructive sleep apnea, if hypertension is not being controlled with meds. Asthma, what would we do for this? Trial treat, trial hold, what? Well, do we know if it's asthma or not? Well, what do we need for the diagnosis for asthma? PFT, so trial treat in this place, this one specifically doesn't really make sense because we don't know if it's asthma. But if we ruled out these other things, then we would order a pulmonary function test. And if we have the diagnosis of asthma, we would treat. Dyspnea, shortness of breath, right? That's a red flag across all of these. So newer sudden onset meaning, right, like exacerbation of underlying condition, COPD or asthma. So if you see dyspnea and otherwise, patient that was normal before this thinks some either exacerbation or new onset of something else. Real world, if I have a patient comes in dyspnea like a young, healthy person in the ER, I get very scared because now I'm thinking what? Pneumothorax, pulmonary embolism, something along those lines, okay? Remember we talked about bloody cough? Majority of the time when you hear a bloody cough, it's not really bloody cough, it's just blood in the upper airway, whether that's a nosebleed, whether it's oral, they dip their tongue, or they have some type of bleeding disorder. True. Coughing up blood, think bronchitis is the most common cause, right? Bronchitis, because those bronchioles get irritated, and then you're going to have some of those capillaries start bleeding. Chest pain, remember, is it reproducible or not? So if it's ribs, intercostal muscles, if I press on it and do that, typically it's going to be an outer wall, and it's going to be from some trauma or overuse. If I can't really pinpoint it, pleural pain, generalize that vague sensation. Pain localized, if they say it's not, you can't reproduce it, but it's right here, we're thinking malignancy or potentially an abscess. All right, so subacute cough, what's our time frame for that? 3 to 8 weeks, right? So what are we thinking? Hey, post-infectious cough, what else could it be called? Right. We just talked about this, so which one is it? It's going to be A, bronchitis, right? Could you see it in these other ones? Yeah, for sure, but not the most common cause for our purposes. The majority of your people in America are not walking around with tuberculosis. Everybody knows coughing up blood like Doc Holliday. Other airway disorders, so foreign body aspiration, that classic triad. Kids playing around with something, they take it, they cough, they have stridor wheezing as it's moved down the airway or it gets stuck, and then diminished breath sounds because it's blocking some bronchioles and air is not moving in and out. Upper airway is the most threatening condition or location because it's too big to pass down further. Emergency measures. Backloads and chest compression, what's the age for that? All right, so if I say 18-month-old baby with suspected foreign aspiration is difficulty breathing, should you do backload chest compressions or Heimlich? All right, so remember, per the slides, less than 1 year old, it's backload chest compressions. If they're greater than 1 year old, you're going to do Heimlich. You're going to get plain neck and chest x-rays. If it's witness and maybe it's not showing up on the x-ray, what are some things that wouldn't show up on x-ray? Wood, plastic, glass. So we're going to go ahead and order that CT to rule out that there's any foreign body. Now with epiglottitis, right? What is this? What is that word telling you? Yep. So epiglot and then itis, right? So inflammation of the epiglottis. Those are the most common, right? So influenza type B before vaccine. We talked about that. That was the Oregon Trail, right? People aren't getting vaccinated, they're going to die. And then strep and staph, and then these are going to be your treatments. So unless I, very specifically say, I don't want you to think MRSA unless I give you a clue, like they are admitted to the hospital for the past 2 weeks and they've developed these symptoms, then we can maybe think MRSA because nosocomial is more intense. But otherwise, unless there's something very strongly, you're going to go with that third generation. With that too, you guys see dysphagia, drooling, distress. They may be in a tripod position, protecting their airway. They may be in a sniffing position. Look at your patient, and then that x-ray of the neck, you're going to get that thumbprint sign. And literally just a big thumb pushing on the epiglottis. Croup. Out of all these, that's really the only one you can't use a word to break it down to determine it. The rest of these, you can look at them and kind of have an idea of what's going on, right? Bronchitis is just inflammation of what? Bronchi, right? Bronchiolitis. So small airways, the bronchioles, right? It's inflammation of that. So croup. Anybody know the origins of the word croup? It's a Scottish word. It was, can't remember. It's but it comes from Scotland, and then it was used in English, and they use it specifically to describe that barking sound with these. So parainfluenza virus is our most common. Patient comes in, they have a barking cough, stridor, or hoarseness, and they have that steeple sign and chest x-ray or neck x-ray. They can croup, single dose of steroids. Now, if there's severe respiratory distress, you're not just going to give steroids and discharge them, right? You're going to bring them in, admit them, do whatever you have to do. But otherwise, if they're stable, it's going to be a single dose of steroids. Bronchitis, already talked about that. It's going to be the most common cause of what? There you go. Bronchi that appears with cough. What else could do that? Yeah, chronic bronchitis, right? Diagnosis is clinical, avoid antibiotics, right? It could also mimic pneumonia and chronic bronchitis, kind of, you think of those two, but chronic bronchitis is usually going to be less severe. They're not going to be as sick or as ill as a patient with pneumonia. Bronchiolitis, big children, right? So smaller airways, RSV is going to be our #1 cause. They could have bloodstream sputum as well too. Diagnosis would be clinical and a rapid RSV test to determine that underlying. What do we need to reassure our patients about with that? Yep. And come back if it's red flags are developing. Cystic fibrosis, right? Remember that's a childhood disorder. It's going to affect their liver and their lungs, or their pancreas too as well. That increased mucus production, and that's from what type of transport error? It's chloride, right? Remember chloride, it's not calcium, it's not potassium or anything like that, it's chloride. Frequent pneumonias, right? These kids are sick because they're not moving air, because that mucus will block the alveoli and the airways. What kind of, for missile obstruction and restrictive pattern, what kind of test would I need to order specifically? Just the standard spirometry? It's going to be the body, right? The body for this. mixed restricted pattern. That's an indication that you're not doing regular spirometry. You're going to do the full bore so you get that residual volume. And then this is that sweat chloride test, right? This is diagnostic of cystic fibrosis, and these on at least 2 days, right? So if you say, hey, a patient came in with a positive test and they don't say cystic fibrosis, we're thinking cystic fibrosis as soon as we see this test. Not really used for diagnosis of anything else, so the rest of your career, just always think cystic fibrosis when you see this test, this sweat test. Bronchiectasis, we talked about this. This mimics what? Yeah, COPD, right? It can be a very similar presentation. You think this, I want you to think elderly females over the age of 60 is the most common group that's diagnosed with this. This is that frequent infections, causes issues with the airway, and then you have dilation because inflammatory effects, pooling of mucus, and increased pneumonia risk. So what are medication I would want to avoid this patient? Yeah, I don't want to block their cough because I want them getting all those secretions out. So I never would give these patients any type of cough suppressant. Chest X-ray or CT, you're going to see those tracks or the signet rings, right? Remember those? That's fibrosis of the airways, the bronchioles. And then 50% from cystic fibrosis, 50% associated with smoking and infections are as well. So if we see this right here, positive melanocortin test, what are we thinking? All right, so let's go through these answers. Calcium transport dysfunction? No, because what kind of dysfunction are they having? Chloride. So that one's out. C is out, right? Anything about venous thrombi? No. What about E, antitrypsin accumulation? We talk about what is only antitrypsin we talk about in this course? A1 antitrypsin deficiency, right? So we're thinking that's like a COPD, so that's not it. So airway blockages, and why is it blocked? Yeah, very thick, tenacious mucus. So asthma, lecture 7, is reoccurring versus COPD, which is a chronic condition, right? Asthma is hyperresponsiveness to some type of triggers. Usually diagnosed prior to age 25, childhood, one of the most common childhood diseases. Atophy, what does that mean? Yeah, it's a hypersensitivity to some type of allergen. So what would those symptoms be? Diarrhea, rhinitis, right? Just think of any type of allergy symptoms, right? So what could you have? You could have like some rash, some eczema, watery eyes, hay fever, all those classic allergy symptoms. And then tobacco exposure is a big one. Infection, right? These guys are more prone to secondary infections with asthma. Common triggers. Allergens is going to be your most common, but typically there's going to be some underlying trigger, right? So whether it's work exposure, some type of irritant, they work in the motor pool, or they're a cook, right? So cooking gases and some of the stuff we can cook can cause that to be a trigger. Infection, exercise, right? There's a number of things. You can have cold-induced asthma as well. Less common triggers. What was this triad a part of? Samter's triad or asthma triad? Y'all remember what those three were? Asthma, aspirin sensitivity, not an allergy, right? And then what's the third one? Nasal polyps, right? So that goes back with that atopy over here too as well. You may see that with somebody with chronic allergies. But you see anybody with aspirin or NSAIDs and they're having an asthma exacerbation, it should be a red flag. You DC those meds. Clinical features. So it's episodic, right? If they're having continuous asthma attacks nonstop, are they controlled? No. And the goal of this is not, we're not going to cure it. It's to identify those triggers so they can avoid them and have them some medication so they're not using what every day. That rescue inhaler, that's Sala, right? That albuterol. We don't want to use that every day. Now we make our diagnosis, spirometry. So if obstruction comes up on the initial spirometry, we do the reversibility test with asthma or the albuterol, we get that decrease. If we're still thinking it's asthma and the initial spirometry was normal, what would we do? Yeah, the methacholine challenge, right? And what we're looking for that is what? Say it out loud if you know it. Yeah, so 20% decrease at 4 milligrams. Make sure it's 20% before I go on top of that. Characteristic fatal asthma can occur at any severity level. So they could be intermittent, mild, moderate, or mild, moderate, or severe. They can still die from this. Again, you're going to have that chart on the left on the test, but you will not have the one on the right. So all we're looking at is ages 12 and above. Go up here, and then we determine our symptoms. This is the initial visit, and it's going to determine. So if they're intermittent, they go on step 1, right? Pretty straightforward. That's just a PRN SABA. If they're mild, you come down here and it tells you what step to go, right? So that's our initial treatment. It's pretty straightforward. You just have to remember these 3 right here, these 3 steps. Now their follow-up, right? Make sure you're paying attention down here to what this says. Same thing over here, all this bottom portion. So if they're like step 2, they're never using their SABAs, their symptoms are greatly controlled, could we consider moving down to a step 1? Yeah, they've been stable for 3 months. So 3 months is that key. You're going to see that right in here, right? It says it over here too as well. So not everything's just going to be stepping up. We want to step down if we can. We don't want to keep patients on multiple medications if we can avoid it. Nobody wants to live their life that way. So look at your patient. If it's improving over 3 months and they're stable, we can consider stepping down. If it's worsening, do we need to wait 3 months? Yeah, you're not going to say, hey, I know you're having difficulty breathing. This is impacting your life, but I want to give you a 3-month trial. No, you're going to go ahead and step up and increase, right? That 3 months is just for decreasing the step. Don't worry about this one on the left, because we're going to be using these step 3, right? So don't worry about the gene strategy part. This is just a kind of another way of looking at that chart to break it down so you're not having to go through all this stuff right here. Same thing. So right here, go to persistent moderate. What is this medication right here? Medrol. It's a long-acting beta agonist, right? Can I give that by itself to an asthma patient? No, because why? So it's not actually doing anything for the inflammation. It's masking symptoms. So if I give that LABA, their airway could still be inflamed and getting permanent remodeling. That's no good. So what about COPD? Can I give a LABA by itself? Yes. Understand that key difference. And then know your exacerbations. Read the whole question and look at your chart. Y'all shouldn't be missing these questions because I'm giving you the chart, right? Asthma exacerbation, right? It's anything above their baseline. Same thing with COPD. So is it worsening? Are they have an increase in symptoms, increase of SABA use? Are they in acute respiratory distress? So if it's mild to moderate, not described as severe life-threatening, right? So patient comes in, if they're tachypnic and their SATs are dropping, is that mild to moderate? No, so look at your patient. Would that be, the first question is, would you feel safe if you're sending your kid home like that? If you don't, then you're gonna think it's more the mild to moderate. But we're going to give them oral steroids first dose as soon as possible, right? We're not going to delay that even if we're in an outpatient clinic. Give them to them as soon as possible. So we want to reduce that inflammation. That SABA, when we discharge them, not PRN right now. For 1 to 2 days, they're going to take it every 4 to 6 hours religiously to prevent any exacerbations. 5-day burst of oral steroids. What about COPD? Do we give a 5-day burst? 14. Yeah, we're going to give a longer burst for COPD versus asthma. But look at your patient right here. So posturing, what posturing would that be? Tripod, they're leaning forward. What else? Yeah, well, the posturing specifically, right? They could also be just putting their nose out of that sniffing position. And it's not going to say sniffing position on any test. They're just going to tell you the patient's leaning forward with their nose in the air. That's cluing you that they're in the sniffing position. Loud wheezes, tachypnea greater than 30. Now, why is it respiratory acidosis or alkalosis early on? They're hyperventilating, trying to catch their breath, so they're blowing off all that CO2. As they start to wear out, what happens? They get tired, they can't breathe as fast and deep anymore, and then their CO2 starts climbing. So kind of put that in with how the patient's presenting and what you think is going to happen with that ABG. And then life-threatening, right? Wheezing is good when you have an asthma patient. If I hear wheezing, that means air is still moving. If you have an asthma patient and their clinical presentation is not improving and then you're not hearing wheezing anymore, does that mean the wheezing is cured? No, that means there's no wheezing, meaning they're not moving air at all anymore. We're impeding respiratory failure. It's about to happen. But you're going to put all that together. Stats are going to start falling because they can't compensate. Breathing is going to increase. We already talked about the ABG. At that point, if you're getting that, you need to be prepared to intubate and admit them to the hospital. So normal FVC rules out what? So if they have a normal FVC, they don't have a restricted, right? And then decreased FEV1, FVC is indicating what? Obstruction, right? When we think about that patient, what's the first thing that diagnosis we're thinking in a 19-year-old? Asthma, okay. Now let's say I did this test, 19-year-old female, and I didn't get reversibility. What else could it be? Yeah, the A1 the deficiency, right? That could be your kind of zebra on this one, is if they don't have reversibility. But continue with our symptoms. So now we have 1 to 2 days per week, and only woken up night with symptoms twice in the past 6 months. So now we would go to our chart, right? There's only 3 steps it could be. So using our chart, what is it? It's 2 days per week, current symptoms. Maybe that second row right there. So what does that say right there? Less than 2 times a week, so that matches. And then what was the other one? Twice in 6 months. So go down here, nighttime symptoms. What does that say right there?
Less than.
I can't actually read it, so I'm asking you.
Less than 2 times.
Less than 2 times.
Yeah. So let's say, so what is our diagnosis, or what is our treatment going to be? Yeah, because she's intermittent, right? Now, if I said she had more nighttime frequencies, but she's only having those symptoms so many times during the day, do I go to intermediate or do I go to mild persistent? So whatever symptoms go to the highest is what we're going to go with. But for her, she's intermittent, so it's as needed stop. So this time we're going to use that other chart, that follow-up chart. Okay, so we go to our follow-up chart on the left. Immediately we're going to go to the above 12. We're going to look at those. And then what were his symptoms? Is that he uses rescue inhaler 3 to 4 times a week. Where do we see that on here? So this guy right here, right? So what does he fall here for that?
Very poor.
So is it controlled, well-controlled, not well-controlled, or very poorly controlled?
Very poor.
Not well-controlled, right? And what else? Reports waking up about once a week with nighttime symptoms. Well, what are we going to do? We're going to add a daily dose of ICS. So we moved up on our chart right here from step 1 to step 2, right? Because the symptoms are worsening. All right, COPD, think old smokers, right? What's the average age of onset for this, or diagnosis? 40 to 50 years old. Do they have to have a positive smoking history for COPD? Yeah, they don't, right? So if I said like somebody works in an industrial plant around hazardous gases for the past 30 years, would that suffice? Yeah. 2 phases, that early onset is going to be chronic bronchitis, and that is also called the blue bloaters, right? Remember that picture we talked about? That's going to be characteristics of that prominent cough with excessive mucus production. They're going to have rhonchi, meaning you're listening to them, you hear rhonchi, they cough, clear secretion, and now it's clear to hospitalization. Then as it progresses, right, so chronic bronchitis is damage to the bronchioles, right? So that's going to be, or the bronchi, that's going to be the decreased cilia because the smoke and the toxins are destroying that, so they can't clear secretions very well. They keep smoking and keep going, they're going to turn to emphysema, which is that permanent destruction of those terminal airways and just damage to the alveoli. You're going to have air trapping, hyperinflation, with your pink puffers. Prominent symptom of this is dyspnea, right? Shortness of breath, even at rest. So they're stuck in a wheelchair, nasal cannula, they can't breathe. Age 60 and upwards, right? So this isn't the first onset. Chronic bronchitis is going to be early, and emphysema. Then you're going to see overlap between these two as they progress. We already talked about that very decreased breath sounds because they can't catch their breath or hyperventilating because their lungs have lost their elasticity. So they're not able to push that out. So what else is that going to do on their PFT? Besides being obstruction, what else?
Restrictive.
What's that? How do we differentiate chronic bronchitis versus emphysema on a PFT? Yeah, so their TLC, their total lung capacity, increases. Chronic bronchitis, their TLC is going to stay the same, but with emphysema, we're going to see an increase in that TLC because they're hyperinflating and air trapping. Their lungs are getting bigger. So you're going to have that on your chest X-ray too, right? Hyperinflated, flat diaphragms. So remember our gold staging, we're going to use our FEV1 for that. That is not going to be, has nothing to do with our treatment plan, right? It's going to be based off their symptoms for that. Notes on COPDs, you can use SABA or LABA. We've talked about that. There's drying agents, right? So oral corticosteroids, and what was our first that we give an asthma patient? 5 days, and then COPD is going to be longer, right? And then you're going to need to know those antibiotics, and we'll go over that chart here in a second, because the hallmark of COPD is frequent infections, at least one a year. There's that chart again. So real talk, does anybody not know how to use this chart? Right? Raise your hand if you don't, like this is not to embarrass anybody, because other people may have the same question. All right, so we come up here, we have our PFT, right? We look at those FEV1, FEC ratio, and FEC. FEV1, FEC ratio is going to tell us if it's obstructive or not. FEC is going to tell us it's restrictive. You're going to see that right over here, right? So for asthma, we're looking at lower limits of normal. COPD, 0.7 of predicted. And then for FEC, it's decreased. For adults, it's the lower limit of normal. So I come down here, I've looked at these, and then I determine is my FEV1 increased or decreased. If it's normal, it's a normal pattern. I go down here. If I'm still concerned about it being asthma, I can go ahead and do that methacholine challenge, and I'm looking for a drop in my FEV1 by 20% at 4 milligrams or less. Restrictive, I just care about my FEC. So my FEV1 FEC ratio is normal, but my FEC is decreased, which means lower limits of normal. Then I'm going to go down here and follow that. Obstructive defect, right? So I don't care about my FEC, that's normal. We're talking about FEV1 FEC ratio. And with this, I'm determining is it asthma or COPD. If I have obstructive on my initial pulmonary function, I'm going to do what test? Versatility test, right? So you'll have this chart. Looking, if I give albuterol, so on that thing it's going to say post bronchodilator, looking for this right here. Greater than 12% and 0.2 liters. If it doesn't reverse, I'm thinking COPD, right? Everybody understand that? Then mixed pattern, right? That's going to be restrictive and obstructive. And then what test do I need to order for that? The BOD-POD, right? I need to order the full test because I need to see that residual volume so I can determine, what does the residual volume allow me to determine? Yeah, TLC is total lung capacity. Without that residual volume, I cannot determine my TLC. Those management guidelines again, right? The big key delineator right here is hospitalizations or 2 or more exacerbations. If they've had any hospitalization or 2 or more, I'm automatically going to go to Group B, which is by LABA plus LAMA. And then if I have a CBC, my sonofills are greater than 300, I'm gonna go ahead and add the inhaled corticosteroid. For over here, right, group A or B, I'm determining it's gonna have the same amount of exacerbations with no hospitalizations. And then is it dyspnea with strenuous or dyspnea with normal activities? If it's just dyspnea with them running, working out, then I'm just gonna start them on a SABA or a LABA. If they're still having some with daily activities, then I'm gonna go ahead and add that LABA plus LABA. COPD exacerbations. All right, we've already talked about that. If they're already on a SABA or a SAMA, we're gonna add that. We're gonna give them that oral steroids up to 14 days, typically it's 10 to 14, and the antibiotics. So come over here, we're gonna look at them, right? So uncomplex exacerbation, they're stable, going on, we're gonna go with these medications. Then if it's complicated, then we're gonna go with amoxicillin, fluvinate, right? When to refer, so onset before 40, what else could that be? Yeah, AATD or AAT or A1 antitrypsin deficiency. And then despite your treatment, you're on maximum meds and they're still having exacerbations, they need to go to pulmonology. Severe worsening hypoxemia is going to be your number one reason for admitting of these patients, right? So what are they normally walking around at? Low 90s. So think about their baseline for exacerbations or hospitalizations. That dyspnea is worsening. They're no longer able to compensate. Anything's worsening over baseline, then with the exacerbation, they may need to get admitted. Do I want to start this patient on a chronic COPD patient on like 100% O2 non-rebreather 15 liters? No, because I'm going to knock out their hypoxic drive, right? Because they are chronically sitting at a high CO2, so their body doesn't respond the same way. So they're going to sit at that high CO2. Now their body is responding. If they're hypoxic, they increase their breathing. So if I knock it out by giving 100% FiO2 by 15 liters on non-rebreather, then it's going to knock that out, and they're going to start not compensating. They're going to fail even more. Going back to the AATD, right? It's a genetic error that prevents the inflammation of the lungs. The non-smoker, 20, 30 years old of age. And I don't know if the slide said it, but now you guys know it. There's a blood test. We're going to analyze those levels, AAT, right? So we need to make that diagnosis. That's the way we're going to do it. And then if they smoke, you're going to see worsening of those symptoms and probably an earlier onset for diagnosis. Maybe a teenager if they started smoking like in middle school. Okay, so what are some things that stand out to you in this question?
Goal 3.
Yeah, he appears confused, right? So that's telling you that may be the first clue that you see with this patient is that altered fusion. Does not respond at all. So you talk to the wife and say, hey, is this normal baseline? Is this how he normally acts? And I know he's usually sharp. That may be an early sign that they are starting to uncompensate or decompensate and they're not able to be a reliable historian. The major comorbidities, there's analama, analaba already. Note 82. Is that good or bad? So is this patient, is this something where you're going to be like, well, let's give you a trial and see how you do and we'll have you follow up tomorrow? No. So going through these, this is a pretty straightforward question, right? So the altered mental status, obviously that hypoxia is starting to affect them. That's good too, 82%. Diminished breath sounds. So what are we thinking? Yeah. So steroids are not going to impact this because this is an acute process. Not going to give anything for his cough. For the pulmonology, they're going to tell you no, go to the ER, call MOD, get him admitted. And he's having an active disorder. Can we do PFTs on somebody with active conditions or active symptoms? No. So it can be transferred to the hospital. All right, lecture 9, severe obstructive sleep apnea. Just think about that. In the test, as you see OSA, they hey, Mr. Rakowski. The overweight, middle-aged guy, right? That's me. sign of that you have retired from the military. It's a rite of passage. Hypertension, right? Talked about that multiple times. Is if you have somebody who is not responsive to medications for hypertension, think OSA. Daytime somnolence, what could we use to determine that or get a better evaluation of that? It's that Epworth sleep scale, right? So Epworth, that would be something you can give your patient to determine if they truly are having those symptoms or the severity of those. And then loud snoring. Do you have to have snoring for diagnosis of obstructive sleep apnea? No, but typically they're going to have that. You're going to have to know these AHIs, right? What these ranges are: normal, mild, moderate, severe. Know how those differentiate. So 0 to 4, normal, right? Do I do any treatment? They don't need anything. Even if they're symptomatic, I'm not going to do anything for the sleep apnea. We can determine if there's an underlying cause and kind of work it up more. But if they had the sleep study as normal, then they don't have it, no treatment. Mild cases, manage risk factors. What are those risk factors? Obesity is number 1, right? What else? What's that? Yeah, but I don't know if you can really manage that besides saying do some neck exercises, don't have a fat neck. But it's a risk factor, right? But you can't really manage it. So what else could we manage? Yeah, just common sense like stuff, right? None of this shit before bed. No sedating medications. It's going to worsen it. Alcohol is the number 1, right? And weight loss. So with those patients, mandibular device first, least invasive, we're going to try that. Now moderate, right? What can we do for this? Just to make it simple, what's the gold standard treatment for CPAP, right? About the only one you can't, it's really not indicated is that mild. There's still plenty of patients that are mild sleep apnea that have CPAP, but typically you want to try something that's least invasive. And for insurance companies, the cheapest thing possible, right? So you're going to go with that mandibular device, moderate, through those. Now severe cases is where you start going into those, right? So CPAP, that's surgical, where they start removing all the soft tissues in the back of the throat, right? And then that Inspire, that nerve stimulation, that stimulates the tongue to constrict so it doesn't relax in the back of the airway. OHS, right, obesity hypoventilation syndrome, what is their problem? They're fat, yeah, I like that, right? Battalion commanders and sergeant majors will love that when you say, like, what's the sole problem? Like, he's fat. They're like, thanks, doc. Like, well, give me the diagnosis. So BMI greater than 30, they're also going to need to have OSA for the diagnosis. And that thing that differentiates it is during the day, that PCO2 is climbing, so they're going to be hypercapnic. CO2 continues to increase. That's because the obesity blunts their ventilatory drive, so they're not responding to CO2 like the normal person would. Because if your CO2 increases above 45, what does your body automatically do?
Hyperventilate.
Yeah, so it's hyperventilating, or start taking deeper breaths to try to blow off that CO2. In these patients, that reflex is no longer there, so their CO2 keeps increasing. And then what do we want to do for these patients? What's the number 1 thing they need to do?
Send the dietitian.
Yeah, they need to stop being a fatty, right? They need to lose that weight. So we're not going to go in depth as far as like treatment options and just decrease weight. But nowadays you have a lot more tools to help you with that weight loss. So is a beta blocker going to help them lose weight? That comes up with the classic question: am I fat because I'm sad, or am I sad because I'm fat? Right. So beta blocker ain't going to help that. Allergens, and I'm just explaining why you're fat. 3 pillows to sleep. I mean, you could do that. I sleep with like 8 pillows, man. I'm just got a little fort in my bed. That may help them, and that may be a clue that, like, initially when a patient comes in, they're like, "Hey, I get some relief by putting all these pillows up on me, and kind of propping myself up at night." But it's not really going to help them with sleep apnea. Noise cancellation. That's cool, but it's not going to help them. So weight loss is what they need, right? Because they're fat. So that AHI, right, that's what we care about for OSA. For severe sleep apnea, what else could indicate that they're having sleep apnea if their AHI is lower for severe? Is that oxygen saturation below 90% for how long? Right, you're 20% of the study, right? But we're going to be nice and be straightforward. So AHI 3, is that normal? Yeah, so anything under 4, so what do you tell them? I wanted to put an answer in here that just give them more ribbits. Everybody know what ribbits are? Don't know what that is? Is that bootleg energy drink? Shit, man. I had a medic go into SVT on deployment from drinking ribbits, and it was like his platoon sergeant brought him in, and I was like, he ain't acting right. Check his pulse, it's like a hummingbird. So and I was like, dude, what have you been doing? And he was just like, well, we've been on Overwatch for like 12 hours, and I just brought a cooler of ribbits. So that diet of nicotine and ribbits, that was a very scary one. I had to convert them in the aid station. That same medic got a TBI, cracked his skull because he took the padding out of his helmet. He said it was uncomfortable. So as soon as they got hit, the helmet came down, cracked his skull. He stayed in theater. He is a first sergeant here on Fort Sam now too.
Oh, yeah.
All right. So is there any questions about anything we got over? I have some more practice questions if you guys want to do those. Do you guys want to do more practice questions? What's that? I'm not going to say that, but here's Puerto Rican. You judge what kind of name? You don't know?
Are these posted on your?
No, they're not posted. All right, so practice ABG. First thing we're looking at is that pH. 7.48. Is that acidic or alkalytic? Alkalytic, right? So if we come down to our answers, we can go ahead and remove all the acidosis and normal, right? So now we're down to respiratory and metabolic. We come down here, is that PCO2 low or high?
Low.
So PCO2 is low, what does that do to pH? Drives it up, right? So what would this answer be? All right, so kind of going further into that, is it compensated, partially compensated, or uncompensated? How will we determine that? So we're going to go back to our pH, right? If it's within normal ranges, it means it's fully compensated. Partially compensated means the bicarb or the exact opposite thing. If it's a bicarb metabolic issue, respiratory is going to compensate. If it's respiratory, metabolic is compensating. So is that outside normal limits? No. So is that uncompensated? Yeah. Partially compensated, how you would differentiate that is if your bicarb is decreasing, so it tends to lower that pH, that would be partially compensated. All right, pH, acidic, alkalytic, normal. Acidic, right? Below 7.35. Now we look at our PCO2. It's increased, right? So is respiratory the cause? Yeah. Now look at our bicarb. Within normal limits? So is this uncompensated, partially compensated, or so which are our answer? There you go. Now we talked about hypoxia. I'm not going to test you on that, but I just want you guys to understand that concept. Would this patient be hypoxic by these standards? Yeah. So if you're trying to impress your phase 2 person, or if you're taking this in, be like, it is a partially compensated or uncompensated respiratory alkalosis with a mild hypoxia, right? So they're going to super yeah. All right. Compensated respiratory acidosis. Got it. All right. So look at our pH. Acidic or alkalytic. And then our PCO2. And then look at our bicarb. Is our bicarb outside normal limit? So it's starting to compensate. Yeah, because it's trying to drive that pH back up, and then what about the O2? Yeah, I think that's a good question too. So it's partially compensated risk for acidosis with hypoxia, not without hypoxia. Sorry, I tried to make these slides last night with a 5-month-old baby just screaming bloody murder while trying to watch the new episode of 1,000 Pound Sisters. All right, PFT. The first thing we're looking at is FVC, and that's going to determine obstructive or restrictive. It's going to tell us if it's restrictive, right? So is there FVC? All right, so for this one, we actually care about right here, that actual right here, right? So is that normal? Yeah, that's good. Now we're going to go down to our FEV1. Is that decreased? Now look at our ratio. So is that obstructive or restrictive? Obstructive, right? Because we care about this below the lower limits of normal. So did a post-bronchodilator, right? And did it increase by 12%? Yep, so it's reversible, right? So what's our answer? B, because it was reversible. All right, look at our FECs. Did it increase, decrease? Right, so 29%, is that good? All right. You may see that, like somebody like advanced, like coal miners, the black lung, right? Also got the black lung. That could be a restrictive disorder. Now, is it obstructive?
Export.
Is it reversible? So real world, I would say this test is probably that post-bronchodilator was done incorrectly. I've never seen a decrease. I mean, anything's possible. So what's our answer? What letter? Yeah, it's not reversible, and it's mixed because there's an obstructive and a restrictive pattern. All right, some practical questions. So do they need to stay at their current treatment with just the SABA or increase? Yeah, so they need that ICS, low dose inhaled corticosteroid, and a PRN SABA. So again, you go to that chart I gave you. On the right, the gold. So what gold is this? Based off, all we care about for this is the FEV1. The gold portion on that chart. What is it? You have the chart right there. Say it loud, say it proud. So FEV1 is 45. That's all we care about for determining our goal, right? 3? Yeah, it's severe. Anybody?
Delta D.
What? D? Or B? What are you saying? There you go. What is this? D? All right, does everybody understand how we got to D? It's a patient with a cough, but they have all these red flags, right? Temperature over 100, pulse 105, respiratory 26. So they're febrile and tachypnic, which is pointing you to what? We have potential bacterial infection, so we're gonna get chest x-ray because that's not normal. Chronic bronchitis, typically vital signs are gonna be within normal limits. Pneumonia, we're thinking a bit sicker patient. So what's the underlying etiology of this? Congestive heart failure, right? The pump is not working, so they're backing up the fluids, right? So going through our answers, how do we differentiate this? A. Yeah, so A, orthopnea is going to be when they first lay down, they start having that shortness of breath. Hyperventilation, are they hyperventilating? No. Acute dyspnea or exertion? Nothing on here saying exertion, right? They're going to bed. Nothing could be further from the truth. Have we even seen this term in our slides? You haven't seen a term in your slides? For the rest of your courses, I can tell you it's probably not the answer, right? I'm a nervous test taker too, so I'm like, shit, man, I must have missed this slide. That's it. I've done that numerous times. That's probably half my iPad career. But, oh, goddamn, I'm going with this one, man. It sounds good. But it's paroxysmal nocturnal dyspnea, right? Because it's after a few hours, they wake up after they've already fallen asleep. All right. If y'all need anything, I can stick around for a few minutes. I'm in the office. I'm also available. If you need anything.
I'll definitely grab a quick drink and study.